Alfons Rooks again, and we're now commencing part 2 of postnatal care, mind and body. Just to give you an overview from what we discussed in part 1, the last bit, uterine evolution and discharge from the uterus, which is also called lochia. The first 2 weeks, the lochia are called rubra. They have a red blood-stained color. From 2 weeks to 4 weeks onwards, the lochia appear more clear and serous. That's why they're called lochia serosa. And after 4 weeks, the color changes into whitish. The uterine subvolution, if the uterus is not involuting normally, because normally the uterus is no longer palpable after day 12, and if there's prolonged red-colored lochia, that points at retained product of the placenta or membranes. The management thereof would be bring her back to theater, do a gentle blunt curettage in operating theater, and give her antibiotic cover. A gentle curettage because if you would remove the lining of the endometrium, the decidua, that could result later on in so-called Asherman syndrome, where, one of the presenting symptoms of which is amenorrhea. If the lochia have an unpleasant smell and there is febrile illness, fever, that points, as we discussed, at the diagnosis endometritis, and broad spectrum antibiotics are warranted. Please allow me to make a small but important detour, and we go back in the times when we had no idea about the existence of bacteria, let alone the Gr A Streptococcus. In the mid-20th century in Vienna, quite a high percentage of mothers would die after they delivered their babies due to the so-called childbed fever. The mortality rate in those days was hovering between 1 and 10%. Semmelweis was an Hungarian physician who arrived in Vienna in 1648 or thereabouts. You see here on the left-hand side a picture, and here is a postcard which shows the general hospital, das Allgemeine Krankenhaus, and you see on the right-hand side, interesting, it's also written in French. So in those days in Vienna they had two languages. And in this brand new hospital they had 2 wards. It was in a day when we didn't know why mothers died after they delivered their babies. The current thinking was that it was due to an imbalance due to bad air or evil spirits. Semmelweis kept track of the maternal death ward, and he observed an interesting and remarkable difference to the area, the wards where women were looked after by midwives. There he found out the mortality rate was between 1 and 2%, in stark contrast to the wards where male students and doctors looked after women after they had their babies, where the mortality rate was roughly 10%. Compare that to the current Australian mortality rate of mothers, which is about 7.1 in 100,000. Semmelweis first tried different interventions, trying to see whether he could bridge that gap. First, he wanted the women on the side where doctors worked to deliver it on their sides compared to on their back. That made no difference. And he also changed how the Catholic priests did their rounds on the wards. No effect at all. And then he observed, very interesting, that one of his friends, a pathologist, died from a cut in his finger after an autopsy. He also showed signs of febrile illness and he died. And that was for him the light bulb moment, the epiphany, if you like. He noticed and he observed that doctors and students attended autopsies usually in the morning, and after that they went to the postnatal ward to do their rounds. He came up with a theory that there might be cadaverous particles well before Louis Pasteur in Paris came up with his germ theory. What he did, very clever, he did an intervention, an experimental intervention, where he encouraged the doctors and the students to wash their hands with a chlorine lime solution before going to the wards. And he observed a sudden and persistent drop in maternal death to 1%. In this chart you see before the intervention the average mortality rate was about 10% here, and there's a dramatic drop to about 1 to 2% after hand washing was introduced. Be aware, some months the mortality rate went up to 1 in 3 women. Unbelievable when we look at those figures with our current eyes. That was the good news. The bad news is that Semmelweis was unable to convince the leading gynecologists. They denied these facts. They didn't understand the underlying mechanism and didn't believe him. And Semmelweis maybe was very passionate, that was good, but when presenting his case and when he published it, he was quite, he did not mince his words, and because of that he made enemies among the influential Viennese, Austrian gynecologists. And the result was hand washing was not introduced. So, what could we learn from Ignaz Semmelweis' battle in the 21st century? He is also described as the savior of mothers. There are 3 lessons to take on board for all of us. First, we have to have an open mind to new things in medicine, even if you feel very comfortable with the current practice. So avoid the Viennese gynecologist Semmelweis reflex. Secondly, if you want to bring about change yourself, use tact and diplomacy skills, be gentle, try to gain respect first before you try to bring about change. That's the art of convincing after gaining respect. And last but not least, always disinfect your hands when seeing patients, the so-called 4 moments of hand hygiene, even when you cannot see the bugs. So no argument here, just do it. That is the end of detour 1, but I would like to do another important detour. And this is not about E equals mc squared, because most of us will agree with that. That's beyond debate. This is about the systemic inflammatory response syndrome, SIRS. SIRS, the definition of SIRS means if 2 or more of the following 4 criteria are met. 2 or more. A body temperature of less than 36 degrees Celsius or more than 38. A heart rate, tachycardia, of more than 90 beats per minute. Tachypnea, respiratory rate of more than 20 breaths per minute. And a white cell count which is low, less than 4, or high, more than 12. Or more than 10% band forms. If 2 or more of these criteria are met, we're dealing with SIRS. That's very important. Why is it important? SIRS is a general, specific reaction of our immune system to an insult, and that insult can be various causes. Here we see an overview. The most common one for us is of course infection, here in purple, bacteria, and that means the combination of suspicion of an infection and SIRS means sepsis. SIRS can also be caused by other causes such as trauma, burns, pancreatitis. What is important to take on board for all of us? As soon as you come up with a diagnosis SIRS, there are 2 possible consequences. One is further deterioration to sepsis, severe sepsis, when there's findings of end organ damage, and eventually septic shock. The mortality rate increases from 7 to 16 to 20 to a whopping 46%. Sometimes, however, SIRS can be self-limiting, for instance, when you have the flu. But what is important for us as doctors, if we find out the woman has 2 or more symptoms consistent with SIRS, we have to treat it as if there is sepsis. So a mastitis or endometritis plus SIRS means aggressive antibiotic treatment intravenously plus IV fluid resuscitation. And if the woman doesn't respond quickly and favorably, she needs to go to ICU urgently. If not, you are entering the cascade of danger. I understand that I would like to do the second detour as well. But let's now go back to our postnatal ward round and look at number 4, the wounds. Various wounds could be there: a tear of the perineum, an episiotomy, or a lower segment caesarean section incision, which is usually a horizontal incision, a phalansteal incision. I exclude here the management of 3rd and 4th degree anal sphincter tears because 2 detours is more than enough, I would think. Let's look at this lady. She is day 3 after caesarean section. Firstly, we see impressive stretch marks and staples, and I would think as well this is a very generous incision. Interesting as well, we see pigmentation of the midline, which is typical for a pregnant lady. By the way, what you see here, the extended abdominal wall, that's normal after a delivery. It's not the fundus what you see, it's the abdomen, which is quite lax after the baby was born. So when you want to find out where the fundus is, you have to gently palpate in the midline until you feel that muscular resistance. Here we see another wound, which is day 7. The wound is slightly reddish, but there's no signs of infiltration here. And here is a little bit of dehiscence of the wound and a minimal oozing. I would think if this lady has no febrile illness, no other symptoms of SIRS, you just treat her conservatively. Mother Nature will do the job for us. No antibiotics, in other words. This is a lady roughly day 12 after a lower segment caesarean section, and we see here a nicely healed wound. By the way, I think the side of the wound looks more sympathetic compared to the first one. In this case, dissolvable subcutaneous sutures were used, which are now the number 1 choice. For obvious reason, I do not want to show pictures of an episiotomy of the perineum here online, but what are signs of a wound infection? I would like to confirm what you already know, fever 1, and there are 4 of the 5 cardinal signs of inflammation. Interesting, those were already described in the year 25 by Aulus Cornelius Celsus, not Celsius but Celsus, and he describes calor, dolor, rubor tumor and penuria, and we only limit ourselves to the number 1, 2 and 3 and 4, which means warmth, pain, redness and swelling, the classical symptoms of infection. We can ask ourselves as well, is there discharge from the wound? What is the nature of the discharge? And can we palpate a mass or even an abscess? After lower segment caesarean section nowadays, a wound infection is not very common at all because routine antibiotics are given at the beginning of the caesarean section to reduce the likelihood of any infection, so endometritis and wound infection and also a bladder infection, UTI. If you would treat a wound infection, we are dealing with Staphylococcus aureus, but usually also gram-positives and negatives, so that will determine our choice of antibiotics. If there are signs of a collection or an abscess, incision and drainage in theory is usually warranted, and we nowadays use a vacuum dressing to make sure that debris and pus will remove, that vacuum dressing will assist Mother Nature in removing any unwanted debris. That concludes the 4th station of attention, the various wounds. Number 5, the legs. It's probably pretty obvious that we are dealing with an asymmetrical swelling of the right lower leg. The leg appears reddish, and the diagnosis is clear. This is a right-sided deep vein thrombosis. We focus, of course, on preventing this as much as possible by early mobilization, by after caesarean section and risk factors such as prolonged labor, obesity. We provide the woman with leg compression stockings, calf muscle compression devices, and we would administer thromboprophylaxis subcutaneously. Of note is that DVT and pulmonary embolism are still one of the 4 major causes of maternal mortality in Australia. Whilst mortality is rare, DVT and pulmonary embolism are in the top 4, together with obstetric hemorrhage, that could be antepartum and postpartum hemorrhage, followed by amniotic fluid embolism and mothers dying as the dire consequences, hypertension and preeclampsia, eclampsia, for instance, as a consequence of a cerebral bleeding. Of course, we need to pay attention to more than just the 5 fingers. I try to simplify it a little bit. Be aware of the option of urinary tract infection, especially if the lady had an indwelling catheter for a while. Pneumonia, especially pneumonia, is common when women had a caesarean section under GA. Nowadays, almost all caesarean sections take place under spinal anesthetic. But GA and risk factors such as obesity, smoking, asthma, etc., they are risk factors for pneumonia. Okay, before we discharge the woman, and we are happy with the 5+ items we discussed before, we need to discuss contraception. The rule of thumb is that the ovaries will not produce an ovum. There will be an ovulation if she's fully breastfeeding 6 times or more per day. If the couple really wants to have even better protection, they could use condoms. Progesterone slow release or progesterone only pill can be used as well, and a low dose combined oral contraceptive pill is also possible. It's for her and her partner to decide. It's for us to inform her. Important that we discuss lifestyle factors which possibly could be modified to benefit the next pregnancy and her future delivery. Be aware that the adage from the past, once a caesarean section, always a caesarean section, is no longer applicable. It's good already to discuss, if she had a caesarean section, whether she is eligible for a vaginal birth after caesarean section, VBAC, or what we call it as well, a TOLAC, trial of labor after caesarean section. If she had a somewhat challenging vaginal delivery, you probably can share with her that second babies usually are born easier and quicker because the first baby had to pave the way, as it were. Then ask yourself if follow-up by a GP or anybody else is required. If she had hypertension in pregnancy or preeclampsia, it's important that we check the blood pressure to ensure that it's returned to normal and that we're not dealing with pre-existing or persisting hypertension. The same applies for glucose tolerance. If she was diagnosed with gestational diabetes, we must repeat a glucose tolerance test 6 to 8 weeks after delivery to exclude type 2 diabetes. This concludes our part 2 of the postnatal care lecture, Mind and Body. Very important that we realize that quite often the sky is blue in obstetrics, and it's good to share the happiness or the disappointment if her expectations have not been met with the mother and her family, and genuinely listen to her story, narrative medicine. Check the 5 top to toe sites systematically when taking a history and examining her. And of course, before you do your ward round, check the vitals, because they are important pointers. In general, if all these 3 are normal, usually she is cruising along from the physical point of view. A friendly, supportive attitude is paramount. Sorry that I need to confirm the obvious, but being in a hurry and rushing through the ward is not appropriate. It's never appropriate. In summary, here we have the 5 issues we focused on today. Mind and mood. Differentiate between physiology, baby blues, and pathology, which could be postnatal depression or psychosis. The breast, be aware what is normal, such as engorgement. Be aware of little symptoms, but differentiate that from mastitis. Uterine involution and lochia. Usually the uterus should no longer be palpable after 12 days, and the lochia should be reddish of color and not foul smelling. Be aware of various wounds, as we discussed, perineal tear, episiotomy and or caesarean section scar, and taken into account as well her legs. If there are problems, how to deal with them. Postnatal depression, I think, refer to a psychiatrist. If it's all mild, mindfulness can be very helpful to empower her to address anxiety and depression and reduce the likelihood of a recurrence. Medications such as SRI can be considered as well. Admission, of course, if severe depression and signs of suicidal ideation. Mastitis. We cover mastitis with antibiotics. If there's no sign of abscess, if antibiotics don't work, we request usually an ultrasound scan to confirm the abscess, and if present, we can ask the radiologist to do an ultrasound-guided drainage. If that doesn't resolve the issues, surgical drainage incision is required, and most often the surgeon will take a biopsy to exclude a sinister underlying cause. If we are dealing with endometritis, broad spectrum antibiotics are indicated, covering the gram-positives and negatives, and the anaerobes. If signs of SIRS, I would think quick IV antibiotics and fluid resuscitation try to prevent her deteriorating into sepsis cascade. If there is suspicion of a retained placenta and or membranes, surgery is warranted where a gentle, blunt curettage and OT is indicated, usually together with antibiotic cover to prevent infection. Signs of wound infections, early stage antibiotics. If that doesn't work, surgical drainage debridement might be indicated. Post-operative vacuum dressing to promote the drainage of blood, pus, etc. DVT of a leg means therapeutic thrombolytics IV quickly. Just a clinical suspicion is enough. Don't defer in a diagnostic test such as an ultrasound scan or doing a VQ scan or a pulmonary artery CT scan to find to demonstrate or exclude a pulmonary embolism. Other complications such as UTI and pneumonia are treated as per usual. This concludes our part 2 of postnatal care. If you think this is useful and helpful, feel free to subscribe to the DAROG channel. That means the system will generate an email to remind you if your next video is available. Any feedback can be given at the daroga@gmail.com email address. Thank you for your time.